Hello, everyone, and welcome to our Smart Diagnosis series. My name is Dr. Obi Oji, and I warmly welcome you to the diabetes topic. So, today we're going to talk about your diagnostic approach to diabetes. In general, I know that as a nurse practitioner, we see quite a bit of type 2 diabetics in our outpatient setting where practice. But sometimes it becomes really difficult to tease out, especially for your younger patients that come in, your 20-year-olds that come in with diabetes. It's kind of hard to tease out whether this is type 1 diabetes or type 2 diabetes. And for that reason, I did recommend just listening in and hopefully clearing up and learning a little more about that. So we do have a case study here. Mr. Ross is a 25-year-old patient that comes in to see you. He's a male patient. He has some symptoms of polyuria, polydipsia, nocturia, and some weight loss of 12 pounds. So he states that he's been drinking quite a bit of water, going to the bathroom constantly for the past 3 weeks, and he just was worried about, a UTI or something else going on. Well, this is some of his history that would be interesting for us to discuss. So, Mr. Ross has no history of autoimmune diseases, no family history of type 2 diabetes. He does maintain an active lifestyle, not currently taking any medications. And of course, we did perform a good review of system, just asking questions. And so again, the patient had mentioned that he had an unintentional 12-pound weight loss over the last month. Blurry vision just happens from time to time. No chest pain, no palpitations, no orthopnea. Of note, you want to know that with his GU that he has some polyuria, nocturia, so he wakes up in the middle of the night to pee about 4 to 5 times each night. And then, of course, everything else was really showed some normal findings. With his physical findings, vital signs are pretty normal. So again, temp, blood pressure is 128 on 78, heart rate is 88, respiratory rate is normal at 16. And if you notice, his BMI is actually just slightly overweight, but he's not obese at all. With his physical findings, again, general would be alert oriented. Patient has, HENT is pretty much normal. Cardiovascular, respiratory, both normal as well. So again, with skin, acanthosis, no acanthosis nigricans, no edema. Patient's everything about the neurological system is alert and oriented, and really there are no abnormal findings. So there are a couple of things that would be interesting for us to start thinking about just based on the patient's the three P's, the major three P's that we talk about in as nurse practitioners in medicine. But if you're thinking about this case, then you really want to be able to think about a couple of things. One would be the patient's age. And of course, you want to know the reason why the three P's are on board in this case. So the polydipsia, polyuria, and polyphagia. So again, you're just going to go ahead and think about maybe getting some diagnostic tools. Again, the A1C, for us to be able to say that this is diabetes, the patient's A1C has to be higher than 6.5. Or it could be that the fasting plasma glucose is greater than 126 milligram per deciliter, or 2-hour plasma glucose is greater than 200 on your OGTT test. And then, of course, it also could be just a random plasma glucose greater than 200 with classic symptoms of hyperglycemia. In this patient's case, the patient has some classic symptoms that you're able to see. So again, for us in outpatient settings, it's always a good idea for you to think about some additional labs that would be helpful in this case. So again, fasting lipids. You want to be able to check the patient's liver function. So getting a CMP, that will be really important. And then the antibodies. So that, again, if you're really thinking and trying to tease out type 1 versus type 2, you want to be able to order the GAD, the glutamic acid test, and the islet thyroxine test will be another one. The zinc transporter test, these would show the antibodies. And of course, the C-peptide would also be important and prudent for us to order those. And then, of course, you want to check the patient's thyroid as well. So here would be the patient's lab results. So you did order the tests, and this is what came back. Patient's glucose levels at 342 to 348, A1C at 9.8. Again, this will be surprising if you're thinking about the patient's age. But again, think about it in terms of A1C at 9.8. The patient is not obese. The patient exercises. They're doing everything they're supposed to do. His urinalysis came back with glucose at 3 plus. Ketones were negative and no protein in the urine. Sodium, potassium, chloride, bicarbonate, BUN, creatinine, and his EGFR with his kidney function were all normal. So let's talk a little bit about your differential in this case. And remember, the whole point of this series is to really show you the out of box, so we call them the zebras, the things that could throw you in your outpatient settings. So you want to understand the types of diabetes. So of course we know the type 1 diabetes. Type 1 diabetes is typically would occur with some type of autoimmune destruction of the beta cells. We find that in youth. So again, in this patient's condition, that would be the first thing you want to think about. Again, with type 1 diabetes, there's an absolute insulin deficiency that requires lifelong insulin therapy. With type 2 diabetes, we find that these patients have insulin resistance, often associated with obesity, lifestyle factors. Again, these patients would have to do some oral anti-diabetics and eventually could progress to insulin therapy. I also wanted to mention the MODY, so the maturity onset diabetes of the young. You definitely want to think about that as a genetic form of diabetes, often diagnosed under 25. And of course, it's characterized by mild hypoglycemia and negative autoantibodies. And that's why knowing the antibodies and testing for those would be really helpful, especially in your younger adults. So let's talk a little bit about this case some more. So again, this patient has 3 classic symptoms of hyperglycemia, so polyuria, polydipsia, and polyphagia. These symptoms often would indicate the body's struggling, really trying to manage elevated glucose levels, leading to significant discomfort and health risks. So let's talk a little bit about type 1 diabetes. Again, type 1 diabetes, we see that, like I said earlier, in your younger individuals with some weight loss, they could have some polyuria and polydipsia. And then, of course, your job as a clinician is to make sure that you're recognizing this early enough, because, again, intervention and management for type 1 diabetes is really crucial. In the case of not really knowing whether it's type 1 diabetes, type 2 diabetes, or MODY, then you want to start thinking about using some tools. So we have the mnemonic, the AABBCC mnemonic, that you want to consider. So again, this is a systematic approach that really would help you to accurately diagnose patients, whether it's type 1, type 2, or the MODY. So again, the patient's age, the autoimmunity, the body habitus, the background, the control, and comorbidities. So we always think about autoantibody testing for diabetes. So again, we kind of talked about that a little bit. So again, autoantibody testing is essential in differentiating the types of diabetes. The GAD antibody is a primary test. So we kind of talked about that. Then you want to think about your 1A2 and the ZNT8. These are all utilized if the GAD results are negative, and they really do help us to confirm type 1 diabetes, which is an autoimmune condition. So in this case, the results came back. You did order your typical A1C, and then you did order the antibody testing. GAD was negative, 1A-2 was negative, the ZNT8 was negative, but C-peptide really detected that this patient's beta cells are still functioning, so preserved beta cell function, because the C-peptide came back at greater than 600. And then, of course, fasting lipid panel typically would show some dyslipidemia in your typical patients. And then, of course, you're screening for metabolic syndrome features. So of note, you want to be aware of this, that C-peptide it does help to distinguish between the types of diabetes, type 1 versus type 2. So levels less than 0.2 millimoles will suggest type 1 diabetes, while levels greater than 0.6 typically will indicate type 2 diabetes or MODY, aiding in accurately diagnosing and treating this patient, of course, knowing what to do next once you get the results back. So applying AABB/CC to this patient case, the patient typically presented with symptoms that could suggest type 1 diabetes. Again, you want to think about the patient's age. You want to think about their symptoms, the lab findings. With AABB/CC method, what this will really help you to do is to clarify the diagnosis and guide you to appropriately manage this patient for optimal patient outcome. So we utilize the MODY calculator effectively. The MODY calculator does help you as a clinician, as a nurse practitioner, or physician assistant, to really identify the potential cases of maturity onset diabetes of the young, which is MODY. And of course, will guide you as a practitioner on when to consider genetic testing for accurate diagnosis and management. So typically, once we get the results back, just like what we did in this patient's case, we have severe hypoglycemia. You want to start with the empiric treatment option with insulin and metformin, and then just start treatment to ensure the patient's safety while you're awaiting the lab results to come back. And of course, when the lab results come back, then you're able to confirm the diagnosis, and then you can tailor the management plan effectively. And of course, individualizing care would be important in this case. And so again, we're adjusting therapy based on the results. So now we've gotten all our results back. We're definitely reviewing the antibody and the C-peptides, and then we're treating, again, based on what we have in front of us. So again, positive antibody would always indicate insulin therapy continuation. We're thinking more type 1 diabetes. Negative antibody with detectable C-peptide would suggest a tapering of the insulin. So you just pretty much just stop the insulin for type 2 diabetes and continue this patient on the metformin. And then, of course, you can think about the oral anti-diabetics. So in this patient's case, again, really just to make sure that you understand what's going on here with C-peptide, whenever it is that the C-peptide is 200 or less, you're really, this is suggestive of type 1 diabetes. Greater than 600, suggestive of type 2 diabetes or MODY. And then, of course, you always want to check that antibody test. So again, we kind of talked about those, the GAD and so forth. GAD is always a primary test that you want to think about. And then, of course, the other antibodies are 1A2 and the ZNT8. Again, be aware that 5 to 10% of your type 1 diabetics would have antibody that come back as negative. So you want to consider that. So again, always consider MODY if a patient's antibody testing was negative, if there's detectable C-peptide, and the A1C is 7.5 or greater at diagnosis. So again, this is not met in this case. Think about the fact that this patient A1C was in the 9s. So again, you want to kind of think about that. Patient also has one parent with diabetes. Again, we're thinking about MODY in this case. And then, of course, we want to think about the MODY calculator greater than 5%. These are all suggestive of MODY. So again, I just want to wrap this up. I'm going to go back to our case so that hopefully we can wrap this up and hopefully this begins to make some sense to you. So remember that the patient had come in and they had symptoms of the 3 Ps, hyperglycemia, right? The patient has been drinking quite a bit of water. They've been going to the bathroom constantly for the past 3 weeks. And so again, we took a look at the labs. We ordered the labs. So I want to again show that to you. His blood work right here. So A1C was 9.8, severe hypoglycemia of 342. He had some glucose in the urine. So again, he's just spilling glucose in the urine. And this is as a result of hypoglycemia. So again, at this, whenever it is that you have labs like that, make sure that you also include your the antibody testing. So I kind of talked about that, the GAD, the 1A2, and then the ZNT8. And these would help to confirm. In this patient's case, all the antibody testing came back negative. So again, I kind of talked about that with the AABBCC. And in this patient's case, this is your classic MODY type of diabetes, type diabetes. So I wanted to kind of talk about that. So again, some common pitfalls that we see in outpatient settings: misdiagnosis rates for diabetes remain high, especially in patients with atypical presentations. It's essential for you as a practitioner to remember that obesity does not exclude type 1 diabetes. Most of the time, this is overlapping, and you want to keep that in mind. And then, of course, we talked about MODY. Patients diagnosed with MODY are often under 25. And in this patient's case, patient is a younger patient. So again, you always want to consider MODY. Frequently test negative for diabetes related to antibodies, suggesting a different genetic cause for their diabetes. So in this patient's case, the final diagnosis was MODY. We always would think about the family history of diabetes, understanding the family history, the patterns. This is really crucial for the patient. A single parent with diabetes and absence of obesity often will point towards a genetic predisposition, suggesting a possible MODY diagnosis. So the clinical considerations for this case: type 1 diabetes would always require immediate insulin therapy, but misdiagnosis as type 2 diabetes in patients with type 1 diabetes could lead to inadequate treatment and increased risk of DKA. And that's why this case study was presented in such a way that you're able to systematically evaluate the patient, order the testing, make sure that you're ordering the antibody testing, not just the A1C, especially in your really young patients. And then making sure that you're able to, and of course the C-peptide, making sure that you're able to make a diagnosis and then treat the patient appropriately. So the stepwise diagnostic process recap would be to confirm the diabetes diagnosis by integrating the lab findings and the clinical features, because again, features you want to rule out DKA. Remember that. That is associated with type 1 diabetes. And then you accurately want to classify the type of diabetes for effective management. Again, if it's type 2 diabetes, then we knock off the insulin. Initially, just start the orals. If it's MODY, then we know that we're not gonna use the insulin at this time. We're just gonna do at least 2 to 3 oral anti-diabetics before considering insulin. So the key learning points for advanced practitioners would always be to understand diabetes classification. That is really essential for your optimal patient care, integrating clinical features, lab results, patient history, trying to put all of this together because that's really important, and that would ensure your accurate diagnosis. And then long-term, you're able to effectively create a treatment plan. And of course, you want to have this patient as a member of your healthcare team. Really, hopefully, both of you are in agreement in terms of lifestyle modification for your diabetic patients. Well, thank you so much for listening to this presentation. My name is Dr. Oji, and if you have any questions, this is our contact information, and we'll see you at our next presentation.